So Jim's my teacher. It was 15 years ago that I met him, and it was really, one of those days where my life changed into a different path because of hearing a lecture like the one he gave today. I'm from Berkeley, grew up in Berkeley, and Jim's challenged me to talk about what has inspired me to get so involved in street medicine. I think it's important for us to look at why do people commit their lives and their careers to something that can be so difficult. And the fact is that being devoted to street medicine has been very, very challenging for me as a physician. But it's, the roots are from when I was in Berkeley and living in, I'm 49, so it was in the 60s. And my father is an activist, and my mother has mental illness, and at a certain point she took me and my brother on the road, and we were homeless. We were unsheltered homeless kids. And it was really scary in the 60s being in that world and being homeless and living on the road. And I decided when I was that little kid, I was 6 years old, and I just said, someday when I'm a grown-up and I'm not the kid anymore, I want to do something to make this better. So that's what drives me, because I experienced the fear of living in homelessness, and I hated myself because of it. I felt dirty. I felt like I didn't deserve anything. And when somebody gave me something, a handout, I felt maybe even a little more dirty, because I was just this little kid that was this dirty little kid. So I feel that, in the position that I have in my life now, that one of the very important things when taking care of people that are unsheltered, who are really the most vulnerable in our communities, and what we know from the data is that they're at very high risk of dying. They tend to be very, very sick and have a tremendous burden of mental health and medical health conditions, that how we treat people is so important. That it's one thing to, throw some medicine at a person, and it's another thing to give them dignity and respect so that they can, together with you, lift out of the suffering that they're in. So really, in the street medicine movement, there's a philosophy about how we care for people, and that we do it with a certain intention. So when I met Jim, it really challenged me to make a commitment to street medicine, and it's been a long, long journey. And I'm going to be talking about Doctors Without Walls, which is a nonprofit grassroots organization that I started in Santa Barbara in 2005, and I want to give some more history here, because I did my residency training in family medicine in Contra Costa County at the Martinez Hospital out there, and Neil Jayasekera over here, Dr. Jay, was my teacher and continues to be my teacher when I was in training, along with a very dear friend of ours named Mark Stinson. And Mark, like Neil, myself, is a family doctor. He worked in the emergency department with Neil. And he was would work all of everybody's shifts, everybody's holidays, everybody's vacations. He would save up his days off to deploy to disasters internationally. And then he would say to me and his other close friends, why don't you come with me to this earthquake? Or he was in 9/11. He was in the pit of the World Trade Center on September 12th with search and rescue. And I have two children. They're 17 and 19, but at that time they were a lot younger. And I would say, Mark, I can't. It's hard enough for my kids that I'm a doctor and that I'm never home, And it's even harder if I'm going to go overseas. Let's look for what we can do right here in our backyard, where there are people living who are very, very vulnerable. And actually, isn't the medicine that you're doing in disasters very, very similar to what we'd be doing if we went out here, right here? So Mark and I founded Doctors Without Walls together, and this was actually his design, this logo. It was very important to him that it be a circle, that it be a white cross on a red background. This has a lot of meaning to it. The staff with the snake is the symbol of the doctor. We named it Doctors Without Walls, and we started Doctors Without Walls in Santa Barbara, but the idea behind Doctors Without Walls has always been that unsheltered homelessness is a chronic disaster, and that the principles of disaster medicine are the same principles that you would use if it's a giant earthquake right now. knock wood, here, and a large proportion of our community becomes homeless and they're sitting in rubble, or if it's the chronic disaster of homelessness that we deal with all the time when you go down and you see people living in rubble, right? So the principles of disaster medicine are what we infuse into Doctors Without Walls. And Mark died several years ago when he was the same age as me, 49, in his sleep. We don't know the cause of his death, but we believe that it was very likely from the exposures that he had with the disaster work that he did. Whether the fact that he was in the pit at 9/11 on September 12th and they weren't wearing respirators, or the cerebral malaria he got in Africa, or whether it was in Katrina when he was working with the blowing winds. We don't know, but he died in his sleep when he was 49 years old, and the work that we do is always in his memory and with his spirit and his legacy, which was to give to the people that are the most vulnerable, and to give with a spirit of, with oneness with our world. So I dedicate this to Mark, as always. So this is Doctors Without Walls. So the motto we have is to think globally and act locally. And I'm going to be talking about how we've done that. So Doctors Without Walls is a picture of one of our teams walking. We have a website, SantaBarbaraStreetMedicine.org. And our teams are always comprised, they're always multidisciplinary teams. And they've been modeled after Jim's program in Pittsburgh, in that we are backpack-based, mobile, urgent care clinics is how we practice. We're really practicing urgent care. And on our teams, we always have a student. We always have somebody who's doing mental health outreach. We have a nurse. We have a doctor. We have what we call a PAC pharmacist. And we have outreach workers. And we partner with the homeless people in the communities that we're serving. So we work in teams, and every member of the team is important. We are a nonprofit organization, a grassroots organization. We have very, very little money. We're always trying to raise money. But the money that we raise, 99.9% of it goes to medicine that is in the packs, or socks, or soap, or the food we hand out. We staff our organization largely with student interns, and really using like the AmeriCorps model, where if we were employing these young people, we would have to pay them 4 times as much, but they're getting an educational experience with us. Many of them are pre-social work, pre-nursing, pre-medical, pre-law, and they're wanting to have a life experience to help them guide their career choice. And they've been just an absolutely beautiful part of our organization. So we're really lean in terms of our overhead. We don't have an office. We operate out of our houses, and my mother-in-law's shed is where we store our blankets. And I mean, we're really very grassroots. This is our mission. Our mission is to provide free volunteer medical care for the most vulnerable of Santa Barbara, California, where we're located, when and where they are in need, including in times of disaster, and to provide education and training for our volunteers and others in order to promote the excellent practice of humanitarian medicine in our hometown and beyond. So this is some very significant data that is talked about quite a bit in any street medicine gathering. It's data from Jim O'Connell at Boston Healthcare for the Homeless, and where there is one of the great street medicine programs in the world. And this data is still, it actually I think has not been published yet, but it's data surrounding a group of 119 chronically unsheltered people in Boston, and looking at the mortality, the causes of death and morbidity, causes of disease in this group of people. And at the point, the study started in 2000 when this group was followed, and at this point in 2006, this 119 chronically unsheltered people, 31% of them had died. So following this particular cohort, but also other studies that modeled after this study in Boston, we know that unsheltered homeless people are at a very high risk of dying. So when we do our street outreach, we're always thinking about that this person that we're caring for could be dead tomorrow if we don't really pay attention to what their medical conditions are. And it's not so easy to know that for the reasons that Jim has discussed. So it's really about developing relationships with people, because if you don't develop the relationship, you're not going to know what their risks are. And so causes of death, when you look at the causes of death of the unsheltered homeless population, often the causes are from preventable diseases. So cancer, heart disease, liver disease, respiratory disease, conditions that we can prevent if we can get treatment to people. There's also another slide that I don't think we've included here about the number of emergency department visits for this cohort in a period of 4 years, I think was 18,000 visits. I mean, enormous utilization of the emergency department because there's a lack of access to good primary care or simple urgent care where you can prevent people from needing to go to the emergency department if you can get them the medicine where and when they're in need. So there's a movement in the nation now that's been very exciting called Common Ground. Have any of you heard about the Common Ground movement? One person? Two people. So Common Ground, if you Google Common Ground, look up what Common Ground is about. I mean, that's a whole talk in itself, but Common Ground is a grassroots organization as well. And the philosophy behind Common Ground, the Common Ground 100,000 Homes campaign, is that we can get people directly from street to home, that they do not need to go through the shelter system. They can go right from unsheltered into housing, and that this is a solution to chronic homelessness, is to get people into homes. It's been quite successful. There's a lot of excitement about Common Ground, and the way it works is that Common Ground needs to be invited into a community by a member of the community who just goes online and says, I invite you. And then they will help you as a community organize a Common Ground campaign, which begins with volunteers pushing out essentially a public health survey that asks the unsheltered homeless people and the sheltered homeless as well, in other words, living in transitional shelter, many questions about their health conditions. And the goal is to identify the most vulnerable people and get them directly into housing. And this has been developed in partnership with Jim O'Connell using his data, which was used to create what's called a vulnerability index, which is looking at, if you look at this person living on this street corner, how likely are they going to be to die? And if they're the most likely person in your community to die, do you really want them to die there on that sidewalk, or do you want to get them into a housing? So that's what the Common Ground movement is about. Last winter in Santa Barbara, we organized as a community, not me or my organization, but as a community, 500 volunteers to go out and push out this vulnerability index survey. And 1,500 people were encountered, 1,100 were surveyed. The survey's done in the early morning, like 3, 4, 5 in the morning. Why? Because how else do you know who's sleeping outside if you don't do it in the morning? So people are approached in a very respectful way. They're asked to participate in the survey. The information is put together, and then the vulnerability index is produced to rank people based on their risk really of dying. So we did that in Santa Barbara, and we got some very important information about how many were unsheltered of our homeless people, how many emergency room visits, how many hospitalizations. So I really encourage any of you who might be feeling inspired to look up Common Ground, think about gathering together and inviting that movement into your community. It's very powerful. Okay, so we in Doctors Without Walls, we have 6 programs in 3 areas. The first we call Wraparound Care, and that's where we have our street medicine programs, where we have packs and teams. We go out 3 nights a week, or there's 3 days a week that we go out. Isla Vista is every other week. And this is modeled after Jim's program in Pittsburgh, where one of the first things that he taught me about street medicine is that you need to go to the same place on the same day with the same people so people know you're coming. Because if you just go randomly around when you feel like it with different people, you're not going to build trust. No one knows you're coming. And I've had the privilege of going out with Jim in Pittsburgh and experiencing that before I started Doctors Without Walls. And, I think there was a McDonald's stop. So, we were in this McDonald's at, 11 at night, and people were expecting him at McDonald's. So wherever it is that you can congregate with people and address their health needs is where that ends up being a stop on our round. So in Santa Barbara, we have, what we've done in Santa Barbara is we start our rounds where there is a meal in a park. So that's how we did it. There's 3 different, Alameda Park, Pershing Park, and in Isla Vista, there was a meal that was always on the same day. So in Isla Vista, it's Mondays. Alameda Park is Thursdays. Pershing Park is Wednesdays. Every one of those days there's a meal. Our teams show up, and we set up in a corner of the park, and over time people know we're there, and then we just set up our clinic. That's how we do it. And so we follow the food, is what we say. The Women's Free Homeless Clinic is a program we developed because we were very concerned about the women, we wanted to have a woman-centered environment for the woman. And what we did is we went to a very beautiful homeless shelter in our community that serves families. And like many shelters, in the daytime, everybody has to leave. They're not allowed in the shelter during the day. They're either supposed to be working, the children are supposed to be in school, so it's empty. And so we said, well, could we come and set up every other Friday in your shelter and make a woman-centered space? So what we do is hot, untimed showers. And we found out that's what the women, we found out, we thought, oh, we're going to do pap smears all day. Like, we're going to go in there and we're going to do all these pap smears. No. First we had to spend a year with women taking showers, doing their laundry, sitting down and talking, relaxing, and so over time now we are doing pap smears, but we were, it's like you have your own ideas about what you're going to do. We have delicious food that's prepared there with a partner called the Organic Soup Kitchen. We have donated clothing that's spread out, on tables that women can come and they can take a shower, do their laundry, get on a new set of clothing, fresh pair of underpants, and just be women, and then we have this, and I love that the volunteers, they come up, our volunteers who run this program come up with their own ideas. So now we have Diva Day, where a beauty school comes in and does beauty, and it's a really deeply meaningful program that we have that we love a lot. The next part is disaster preparedness. The next program, we really believe that we have to continue to train for disasters as part of the work we do. So we've partnered, and Neil's going to be talking about this, the Medical Reserve Corps, which is, he'll tell you more about that. You have a Medical Reserve Corps here locally. So we believe in that. That's an important part of our volunteerism. And then we have educational programs as well, which is always important. So Delbert, this is an example of how work takes a long time. So this is Delbert, and Jennifer is sitting here, talking to Delbert. Delbert is a man, and I'm going to let Jennifer tell you more about him, but look at this home he lives in. Delbert's a Vietnam veteran. He's been living outside 30 years, and nobody had been able to connect with Delbert. A lot of different outreach workers knew he was out there, but he just wasn't coming to the dinners. He wasn't coming to the shelters. And slowly, our teams, with Jennifer's leadership, connected with him, and it turns out he had invasive cancer all over his head. And with Jennifer's patient leadership, she was able to get him surgeries for those cancers and housing. So it's just these kinds of stories that, there are many, many of these stories, but the story has to do with teamwork, patience, consistency, and time. So just some pictures of our teams and how we work in the parks at night. In the winter it gets harder. Our students in our training. This is right now, actually, in Santa Barbara, there's one of the biggest student street parties in the nation, which actually ends up every year being a disaster because of the people, the kids that get down and drunk and hurt. So we go out during this street party. It's a way for us to train. It's a way for us to serve the youth of the community and try and help them stay safe. So that's Santa Barbara, okay? But always in the work in Santa Barbara was the idea that as teams we wanted to spread this work beyond the confines of a local community and work together internationally. So Neil, who's right here, and myself, and Laura, who's one of the doctors, she's our street medicine medical director, went to Haiti together. And this was something that we did because of our belief in the global work, but also because it was team building for us as a team. And I think what was a very beautiful thing is we went to Haiti with this program, Project MediShare from the University of Miami, and this woman shows up. And she says, I want to be part of your tribe. I just feel like I'm like one with you, and I'm from Pittsburgh. And I've been wanting to work with Jim Withers for all these years, and she's a nurse. And so now we're like, okay, you've got to meet you, and that's how it works. Because there's a spirit of the work. And when you work together, you find that there's people that you just feel like they're your brothers, your sisters, your family, and then you spread the work together as a tribe. So I want to give the microphone over to Neil to talk about Haiti. And he first went right after the earthquake, and he's been back 3 times, once 6 months after the earthquake, and once a year and a half after the earthquake, which was when Laura and I went with him. You got your hand.
Hello. How many people here are unconscious?
I don't think your microphone is on.
Yeah, if you're sorry.
Does this one have to go off?
Is it on now?
What you talking about?
Is it on now? Okay. Sorry, how many people are here from Contra Costa County? All right. Contra Costa. I work at the county hospital in Martinez, Contra Costa Regional Medical Center. And, I'm one of the frontline workers in the trenches, and we see our fair share of homeless people in the emergency department. And so I understand their medical problems, the complexities of their care, and the need for good medical care. And so street medicine is something that I think is a concept that hopefully is going to catch on, and it's something that we can hopefully develop in our county as well. And but what I'm going to talk about a little right now is I'm going to try to make the connection between street medicine and disaster medicine, and that there's a lot of parallels. Mimi and I have known each other for years, and she's known I've done a lot of disaster medicine. And she's the one who made the connection. Like, Neil, what you're doing is exactly what I do in Santa Barbara. And I had a hard time sort of putting that together until she asked me to help with a talk that she gave, that we put together for the Healthcare for the Homeless Symposium in San Francisco last year. And there's a lot of parallels. So I'm going to show you some slides from what we've done in Haiti. And hopefully you can sort of believe in the concept that homelessness is a disaster. It's a chronic disaster. And there's a lot of parallels and corollaries to disaster medicine globally or nationally. There we go. So in Haiti, everyone remembers the earthquake. It was in January 2010. 7.0 quake hit at 4:53 p.m. Just a little background about Haiti real quickly. Haiti is very close to the United States. It's about an hour and a half from Miami. Population 9 million. Poorest country in the Americas. People live on average about $790 a year. This is before the earthquake. 30 to 40% of the national budget comes from foreign aid. And it's a country of haves and have-nots. Half the people have no access to basic health care. Half the children are unvaccinated, and half the deaths are due to tropical diseases or infectious disease, HIV, AIDS, TB, malaria, typhoid, and cholera recently. So the earthquake destroyed the infrastructure. It was really kind of weird how the earthquake hit. The majority of the ministry buildings and the government buildings actually collapsed. I mean, it really hit the core of the government. And this is the palace. And I think Mimi's going to show a picture later of the palace. And it looks exactly like this, years later after the earthquake. The only difference I saw was there was actually a gardener out cutting the lawn. So the lawn is like perfectly manicured, but the building is just like that. So people couldn't get to the hospital after the earthquake because the roads were impassable. And we know that people that are unsheltered don't go to hospitals for many reasons, and a lot of it has to do with transportation. And even if you have transportation, it is limited. So this is a vehicle that was crushed by the earthquake, and saw a lot of cars and vehicles like this. Also saw one vehicle that I thought was really interesting. It was a Mercedes-Benz. The top had collapsed from the rubble, and so they just cut off the top. And so they're driving around in a relatively new Mercedes-Benz with a convertible. Good until the rains hit. The hospital's overcrowded, so right after the earthquake, I got to work at St. Damian's Pediatric Hospital. Got called down by a group that had a relationship with Partners in Health, Paul Farmer's group. And so we ran the pediatric and adult emergency department there. It was a pediatric hospital, but the majority of people we were seeing were adults. And so the hospitals are overcrowded. We were just putting people wherever we could find a space. So this is the lobby. We had people outside in the courtyard, people in tents. And the resources in the hospital are limited. So right after the disaster, we had all these disaster teams bringing in sick patients from their field hospitals for us to take care of them. We were the pediatric hospital. We were the tertiary care center. We were the children's hospital of Port-au-Prince. And this is a Brazilian team bringing in a young child who had abdominal surgery. And they had the kid on a ventilator, but they ran out of oxygen. So they brought the kid to us. And there was a problem. We only had one ventilator. And we had oxygen, we only had one ventilator. And so we had a sort of a whole room of people who needed to be ventilated with one ventilator. So we had to make the decision who got it, who got the ventilator. So just to correlate to that, I didn't have to make that decision. The guy who ran the hospital was a priest, Father Rick, and he went to Harvard Medical School, and he was a doctor as well. So he's a priest, he made those decisions, but those difficult decisions to make. But the point is, the hospitals are overwhelmed after disaster, or people have no access in getting there. So go to the people. And this is what is a credo for street medicine, go to the people. So you go to the Idp camps, and this is a big Idp camp in Patientville, which was previously a golf course. So the grass there is pretty brown, but you can imagine that was their golf course. And they had a Idp camp there of, initially it was like 25, and the last time I checked it was up to 75,000 people. And so this is a big homeless camp. Idp camp stands for Internally Displaced People's Camp. It's not a refugee camp. They're not running away from a political conflict. They're just acutely homeless. So this is people waiting patiently in line for food and water. So DMAT came in. I'm a member of the DMAT team as well. They came in and set up a field hospital there, which is great. But that was good for the people in the IDP camp, but the wait was long to see a doctor or a nurse or a healthcare professional. And a lot of people did not live in the IDP camps. They lived in their own little small camps, and they weren't accessible. So we went out and actually did mobile clinics. And so we were actually able to collaborate with the 82nd Airborne. They were actually stationed at Patientville, and we went out in their military vehicles out into the disaster zone, finding people who needed medical care. So how would you do this? This is a small IDP camp. Maybe there's about 4,000 or 5,000 there. There was no hospital, no clinic. We went. We found the local leader, and it's interesting when these camps get set up. Very quickly, people organize and sort of develop a leadership system. And so you find the local leader. You ask them if there's a need. And very quickly, you'll find out, like, no, another team has just been here. It's like, no, we have a huge need. We really need your help. And they know who the sick people are. We would gather all the stakeholders. We wanted to make sure it was a safe place. We wanted to develop the clinic in a safe place where there's a clear entrance, a clear exit. We were able to set up our pharmaceutical cache, our tables, get the team assembled. And then we started seeing people. And so this is in a courtyard of a house that was partially destroyed, but had a clear entrance. There was a gate and there's a clear exit, another gate. And we would literally see 400 to 500 people in these clinics within 7-8 hours. And this is a woman had a blood pressure of like 280 over 120, and she just simply ran out of her. She lost her blood pressure medication because it was gone in the rubble, and that's all she needed. So we were able to give her that. And so We saw a lot of people who just didn't have their medications. And they couldn't go to the hospital because the rubble was blocking the streets, or they had no transportation. They're on the IDP camp. So we had a huge pharmaceutical cache, and we were able to distribute medication with the promise that teams would be coming back in the subsequent weeks to see how they're doing. Like the concept that Jim was talking about, you need to go back. So where do you set up your clinic? A backyard will do. A lot of times it was on the street, just in the street. And if you had to do a physical exam, you would go to a place, where you could find some privacy. If you had to do an exam of where you had to undress people. And so it was amazing. Like, out of the 400, 500 people we would see in a clinic, you would see some people who had some severe emergencies that, had a high likelihood of mortality if they weren't seen at a hospital in the near future. So we had these great military vehicles, and so the 82nd Airborne, we would load up patients in the back, and we'd take them to the hospital. And I worked with Relief International. I did some work with them in Sri Lanka. That's my last name is Sri Lankan, Jayasekera. That won't help you pronounce it, but anyway, gives you an idea of where I'm from. Mobile clinics come in different forms. So this is a tent that we were able to set up in a schoolyard, and can't see the line there, but the line's going out the side. And there's a patient in a cot here who has malaria that we diagnosed, and he's getting treated. We did a mobile clinic in front of the destroyed medical school. They had 5 medical schools in Port-au-Prince, and 3 of them were destroyed. And so this right here, you can see the building in the back. That's the front part of the medical school. So we set up tents. Actually, a Slovakian team set up this mobile clinic that I was able to work with. And it was great because we were able to have the medical students go out and actually see patients, and we were able to train them. So it was a great collaboration. Yeah, some of the principles of disaster medicine is you want to treat infection early. So this is a kid who had an ear infection and was untreated, and now he has mastoiditis, which is a severe infection around the ear, and he came in, he was ataxic, he couldn't walk, he had fever, he was a little confused, and so those are maggots coming out of his ear. That's how bad the infection was. We made house calls. So this is in the Idp camp. This lady had a severe hand infection. She was getting antibiotics 3 times a day. We went to her because there's no room in the hospital. And you want to treat non-earthquake related medical illnesses. So in Haiti, half the people have no access to basic health care. And so this man had undiagnosed cutaneous TB, known as scrofula. So this is a condition he had before the earthquake. And you see all this stuff in the clinics, people that had medical conditions that they had prior to the earthquake. You want to enjoy the smiles. You can't, it's hard to see this, but this is a young boy, Jeffrey, who he's lost both his arms here, and he was treated and somehow found his way back out in the streets and was not doing very well. He was not thriving, and he had tetanus. And so he came to St. Damian's, and we treated him, and I wish this picture came out better, but he's smiling here. And we had 6 people with tetanus. 3 of them died. We knew he was going to make it because we put an NG tube down to feed him, and we come back the next morning, the NG tube was out. He'd pull the NG tube out with his feet. So this kid was a fighter. So I think Mimi, she's not going to talk. So this is after the earthquake. Mimi's going to talk about conditions now and how street medicine still applies years after the earthquake.
So with any street medicine program, there are certain principles of street medicine. You have to go where you're wanted and invited by the community. You have to go to places where the work you're going to do is sustainable. And you have to go to places where you're partnering with the people who are from that community. So it was very important when we were talking as a group about doing an international trip together that we very carefully picked the place and the way that we went. So Neil, the first time we went right after the earthquake, as he mentioned, he went with the program associated with Partners in Health and also with Relief International. The next time he went was with a very well-known program called Project MediShare, which is based at the University of Miami. It's founded by a neurosurgeon named Barth Green. And this group has been in Haiti for decades. And right after the earthquake, they were asked to set up a hospital on the tarmac of the hospital tarmac of the airport in Port-au-Prince. So they set up this hospital, and then it eventually moved into a fixed setting in Port-au-Prince. And this is a program where respiratory therapists, physical therapists, nurses, doctors, who else, can go and spend a week at a time working in this hospital. It's the only critical care hospital in Haiti, has the only respirators in Haiti. So Neil had gone a year after the earthquake, no, 6 months after the earthquake, I'm sorry, and we just went in October. So we very carefully picked the place that we were going to go together. We also picked Project MediShare and this particular program because a mission of the program is to work with the Haitian people to help them build the sustainability of their own hospital and their own community. So this is a Haitian partnership with a program that's been in Haiti for years. So that was really important to us. So when we went back to Port-au-Prince this October, what you can see here is that, you know, the infrastructure, there's still a great deal of destruction. This is the palace, it's still destroyed. As Neil mentioned, they're mowing the lawn. This is the Senate. This is the cathedral where the Archbishop died. And you know, the symbolism that the cross remains standing, but the cathedral was destroyed. It was very heartbreaking for us being at the cathedral because there's so many people living outside, families and children. We had people coming and handing their babies to us in this cathedral. It really broke my heart. But this was downtown Port-au-Prince this month. You still have people living in large IDP camps. This camp is Cité Soleil, which is one of the most violent slums in the world, and this is where we were located, right next to this slum. So we were not allowed outside of the confines of the hospital where we were working, except for special circumstances, which I'll tell you about, which is when we took these photos. You know, there's still tremendous loss of infrastructure. That's garbage in the street, that's piled up. But the beauty of the people, the spirit of the people is strong. And we saw that when we were driving through the town. This is a march. These are people organizing in a march, and they're marching for jobs. These are these beautiful nursing students in their crisp uniforms going to nursing school in a compound where they're taking classes in tents. And the tents were filled with nursing students. So we found the spirit of the people to be strong, even though the infrastructure is still quite broken. So the question we're asking is, how can we go and work in the only critical care hospital in Haiti and do a street medicine evaluation to look for street medicine potential in Haiti? So what we were doing in the hospital while we were there is looking at why are people ending up in the hospital with conditions that could have been prevented if they had medical outreach. And what did our Haitian colleagues think about street medicine, and what street medicine is existing in Port-au-Prince? So while we were in the hospital for that week, we were thinking about these questions and addressing these questions. So this is the hospital where we worked. The picture on the left is looking into the hospital, and the picture on the right is looking out. So we were really locked in, for the most part, into this compound for the week we were there. On either side of this picture are two Haitian brothers. They're twins. They're the Bitar brothers. They're Lebanese heritage, born in Haiti, trained in France. They're surgeons, and they own this hospital and operate it. And then Project MediShare has a partnership with these surgeons to provide volunteer clinical staffing. So this is the team that we were with during the week we were there. We were working 14, 16-hour days, pretty much as long as we could work, we worked. And we just stayed there. So we slept and worked. We lived in dorms, rooms with bunk beds that were right next to the ER and ICU and hospital ward where we worked. So it was just it was an incredible experience. It was very intense. This is the hospital, and what you can see here is, you come in, there's a triage unit, there's clinics in this area. This is the pediatric ward where they're distributing food. I wish you could see these pictures better, but these are some of the beautiful Haitian people we worked with side by side. This is an ambulance, the CT scanner, the pharmacy. It was quite a place. Here we have, this is the hospital ward, and the people, there was 9 beds, and they're all in a circle. The families of the people who were sick had to feed them, bathe them. This is a minister doing a prayer service. So it was a very close environment because we were staying there the whole time, but also the patients were gathered around, like probably the ICU the ICU, med surg, and ER were in a room smaller than this, just one big room. So we learned and we taught while we were there. The picture with me are some of the only paramedics of the entire country of Haiti. Were trained by Project Medishare, and they were our translators. Very, very passionate young men. On the right side is Dr. Theodore. She's a Haitian doctor we worked with. And these are pictures of the many nurses. So the point of these pictures is that in any street medicine program and any global health program, it's working in partnership with the people of the community that makes it a good experience. And that was one of the great things about this program. So when we look at the 6 most common causes of preventable death in Haiti: trauma, stroke, burns, coronary artery disease, maternal emergencies, and infectious diseases. Half of these are from hypertension. Stroke, heart disease, and the maternal emergencies, preeclampsia, all related to hypertension. So when you look at the Haitian people's the diseases, there's a real predisposition among Haitian people to have very high blood pressure at a young age, even though it's not lifestyle associated. They're not overweight. It's just that Haitian people have high blood pressure, and it's been largely untreated. So the idea here is that if we could look at how to get better treatment for hypertension, we would prevent deaths. And so we were there for, just looking at 6 days that we were there, we were actually there for 8 days, but 6 days, we tried to write down cases as we were doing them. We were very, very busy. But we had 40 admissions to the hospital, 20 deaths. So this is coming through the emergency department where we were working, and then admitting people to that little hospital ward that I showed you. 40 admissions, 20 deaths, and 7 pediatric deaths. So we did see a lot of people coming in very, very sick and dying within hours of arriving. Of the people that we admitted, or actually of the 40 admissions and 20 adults deaths, 38% of them were due to trauma. 26% were due to primary neurologic problems, largely associated with uncontrolled hypertension, and then 36% were chronic diseases and infectious diseases. So trauma. As I said, there was a great deal of trauma. The trauma was from whether it was a rock getting kicked up by a truck that was driving down the street and hitting someone in the head, or a rock falling off a building, or someone being beaten or shot or stabbed. There were a lot of violent injuries. We saw a lot of it. And there was a widespread need for tetanus vaccination. We also saw a lot of life-threatening illnesses. On the right, that's a picture of someone with miliary tuberculosis, and their lung is just filled with the active infection. And on the left, this was a man who came in, he'd been shot in the back, and that's blood filling up one side of his lung. So it was, really saw quite a lot of very sick people. In this picture, Neil, who's on the right, is teaching the Haitian surgical residents to put a chest tube into that man who had the hemothorax, and then he's being transported in a flatbed truck over to MSF France, where they had a cardiothoracic surgeon. So it was very intense. And we did save lives. There's no question about that. The time we were there, the people that came, we saved a certain number of them. This man was shot in the neck. The bullet went through and through, and we were able to save him. This woman came in. She had an acute surgical abdomen. She needed an abdominal surgery and ended up living and going home. So we felt really good about the time we spent. This baby Matthew, this beautiful young woman came in. She was 20 years old. She had preeclampsia, in other words, hypertension of pregnancy. She needed an emergency C-section, which she got. Had this beautiful baby Matthew. Now she's going to be going out into the environment that we talked about in the earlier slides, and there didn't seem to be a man that was there as the father that was going to be helping care for her. So she was looking like she was going to be a single mother, and she wasn't wanting to breastfeed. And so with the Haitian people that we were working with, the translators really tried to explore with her, why wasn't she going to breastfeed? She said, well, I don't think I can get enough food to be able to make milk. But then we knew she wasn't going to be able to get formula. you know? So we really worked with her and felt it was a great success that when she left the hospital, she was breastfeeding that baby, the beautiful baby Matthew. We found out there's really no breastfeeding education in Port-au-Prince. So here's an example of a baby that was born at 34 weeks early, prematurely because of preeclampsia. When we don't know if baby Matthew would have been able to live if this mama hadn't been able to be convinced to breastfeed. So breastfeeding, very, very important. So what street medicine exists in Port-au-Prince? There are NGOs that are out working with people on the street. When we were out, the one day that we went out, this is what we saw, one form of street medicine. These are prescription medicines that people are selling on these pillars. It's all over Port-au-Prince. And you can buy really anything you want. Penicillin, antibiotics, antihypertensives, but there's not an organization to this. It's individual driven, these street medicine. Another form of street medicine we found in Haiti, this is how we were able to leave the hospital. On the last day we were there was an opportunity for us to give blood. So if we went and gave blood at the Red Cross, we would be able to leave the hospital. Well, the thing is, in our hospital, as we were seeing people dying, there was no blood. So if somebody came in and they needed blood, like that man we transported in the truck to MSF France, they had to send a family member to the Red Cross to give blood, and then the Red Cross would give them blood to bring back to our hospital. So we decided we would give blood. And that was what we did, and that's how we were able to take the pictures of Port-au-Prince. But I love this sign because it says, here's what you can help to do in your community. If you see someone on the street, you can pick them up and help them, or you can give blood. So we gave blood, sweat, and tears for Haiti. And they didn't tell us that in Haiti they take 2 units. So we were like, those pictures were a little blurry because we were feeling a little dizzy after our 2 units. When we got back to Miami, we were really privileged to have the opportunity to meet Dr. Barth Green, the founder of Project MediShare, in our stopover in Haiti. So we presented to him our idea about street medicine in Haiti. From our experiences in the hospital, from talking to our Haitian colleagues, here was our idea about what would be a good and sustainable street medicine program for a project for Haiti. And he added his ideas in. That you would have a little cart pulled behind a car that would go routinely to certain places in the community, located, in a known place each day. And it would have specific supplies, and it would be a partnership with Haitians and Project MediShare volunteers. And the people served would be able to routinely follow up for their needs because they would know when this mobile clinic would come. And that we would have these goals for diagnosis and treatment. Tetanus vaccination. We saw so much trauma. We saw people, as Neil was talking about, people dying of tetanus. It's a preventable disease. Pushing out that tetanus vaccination. Wound care. This was a big problem. People would get wounds, minor wounds, and they would end up being very serious wounds. We see this often in our unsheltered homeless population. Hypertension. Incredible amount of undiagnosed hypertension. So if we could just do hypertension screening and through the cart, just give simple, cheap medicines like hydrochlorothiazide. We could do a lot to prevent unnecessary deaths. The other thing was there was anemia. Everybody we saw in the hospital was anemic. So if we could do simple anemia testing and give iron pills, breastfeeding education, just critical in Port-au-Prince to teach the women that the formula is not the way to go. And then there's, I think, as Dr. Green noted, some very simple screening you can do for infectious diseases. For example, he says that if you ask someone, are you having a fever every day versus are you having a fever every other day, that's a simple screening for typhoid versus malaria. There's lymph nodes you can feel behind the neck that can be screening for tuberculosis, and there's rapid HIV screening you can do as well. So the conclusion is to begin by acting locally and to be of service to the most vulnerable in your home community, and then to think globally, expand street medicine, that model, to resource poor nations, always using the guiding principles of collaboration, sustainability, and accountability. And this is one of our mottos of street medicine, to go to the people, live among them, learn from them, love them, start with what they know, build on what they have, and of the best leaders, when their task is accomplished, their work is done, the people will remark, we have done it ourselves. This is a picture of dear Mark Stinson and dear Jim Withers. And with the time we have left, I asked Neil if he would talk. He has to run off to the emergency department to do a shift, but I asked him with remaining time to talk about the Medical Reserve Corps of Contra Costa County. I'm sure there's a Medical Reserve Corps of Alameda County, but he knows about Contra Costa.
Hopefully you guys understand the concept or the correlation between disaster medicine and street medicine. And so if you want to start your own street medicine program, where do you find these volunteers? Who is a doctor, who's a nurse, who's going to feel comfortable working out in the field, under a bridge, in the disaster zone, so to speak? And one place where you might be able to get some volunteers is the Medical Reserve Corps. And so I'm going to talk about that briefly. Medical Reserve Corps is actually a concept that started by George W. Bush after 9/11. What happened at 9/11, all these doctors and nurses and medical professionals just ran to the 9/11 site saying, I want to help. You know, everyone saw what happened on TV, and but no one knew who these people were. They weren't credentialed. They weren't vetted out. There was no liability coverage for them. There's no malpractice. No one knew their skill sets. There's no incident command. There was no leadership for all these spontaneous volunteers. So George Bush thought it would be a good idea to develop a system like the Medical Reserve Corps, where people who have interest in working in disaster medicine, who are interested in working outside the hospital, outside the clinic, they could sign up as volunteers before the disaster hit. So when the disaster hit, they could go and be of help. So it's under the same umbrella of the Citizen Corps or the Peace Corps, the USA Freedom Corps. It's a volunteer group. But every county has been given money by the federal government to start their own, and every county has their own mission in what they do in terms of disaster response. So it's organized locally. Everyone's a volunteer. Everyone has to be credentialed. They have to go through a vetting process. They have to get fingerprinted. Their license has to be checked. You have to make sure that that their doctors or nurses in good standing. And so this is our mission statement in Contra Costa County, and we provide, I'm not going to read the whole thing, but basically is to assist the public health department and EMS in times of disaster, or to help out in community events. We do a lot of stuff for health fairs, public education, and also we help out if there's a major disease outbreak, in vaccinating people like H1N1. So we fit within the strategic policy plan for Contra Costa County in terms of how healthcare is delivered, and also if there's a disaster. So in California, we know there's lots of disasters. So why do we need one in Contra Costa? I think you could see from the slides in Haiti that if there's a major disaster, there's a good chance the hospitals are going to be down. At our hospital, if the street in front of the hospital is hit by an earthquake, you can't get people to the hospital. The ambulances can't come. So there's only so many helicopters that are going to be able to bring patients in. So the hospital is going to be pretty much non-functional in terms of the emergency department. So you got to go to the people, and that's setting up a field hospital, doable mobile clinics, maybe partnering with the Red Cross. They'll have a shelter, and you can do a clinic right next to them. And that's helpful because the American Red Cross doesn't do major medical care in the shelters. And if there's anything that smells medical to them, they send them to the hospital, which is going to be a problem in a disaster when the hospitals are already overwhelmed. So this is street medicine. This is the H1N1 vaccination campaign that we had in Contra Costa County. Prior to our MRC, all the medical professionals and the doctors and nurses and people who volunteer for our immunization campaigns every year during the flu season, they came from Marin County. So a few years ago we started our own, and now we have our own volunteers. And so they're doing a drive-through vaccination campaign. People are coming in, driving in their car, filling out a quick questionnaire, and getting their immunization shot, getting their influenza shot. So we have over 225 volunteers. And these are people who will have the mindset to do street medicine. I mean, if you're looking for people who are willing to think outside the box, to go out under bridges, or into homeless camps, who are willing to provide medical care that acutely, these are the sort of volunteers you want. So this is the sleep train pavilion in Concord. There's an orderly line of cars, people waiting to get their H1N1 vaccine. This is the Hilltop Mall in Richmond. So in many ways, that is like a disaster zone, just tons of people just showing up, right, with a healthcare need. How do you make order out of chaos? And that is chaos, right? And I think they're able to vaccinate over 5,000 people that day, and they did it efficiently. And that is street medicine. How do you go off into the disaster zone? How do you go under a bridge? How do you sort of like make this, a medical visit that is worthwhile? So some of our volunteers, they also so health fairs, vaccine clinics, walkathons, cardiac screenings. These are people who want to volunteer. They're members of the community. They want to go out and help out their neighbors. A lot of them are retired. A lot of them aren't. They just are very interested in volunteering. This is a tent outside of, I think, a Kaiser facility. This is during the H1N1. So many people are coming in. They're treating people in the parking lot. So they're doing street medicine in a way. I went to Hurricane Gustav and Ike after the hurricane hit. And these are people waiting at the high school to be evacuated to Houston by buses. And they had all these ambulances there ready to take injured people away, but they had no doctors and nurses. And this is where it would be great if there's a street medicine team or medical reserve corps or people who are willing to treat people medically on the street, in the street. So I think that's, I got to go to work in a few minutes, so I'm going to stop exactly at 11. If you have any questions about our Medical Reserve Corps, I'm the volunteer team leader. You can contact me there.
Okay.